Hello, everybody. Recording live from somewhere. This is Zach, couples with episode number 85 of the Movement Debrief. And tonight, folks, it's going to be a beautiful day in the neighborhood. We're going to talk about mandibular retrusion. What's the deal with that? How do you get a retruded mandible? What you going to do about it? Stay tuned. We're going to talk about GIRD. What happens if your shoulder internal rotation is sorry AF? And what if you're a baseball player and you don't have that IR, fam? Stay tuned. I'll give you the answer. And last but not least, we're going to talk about distance assessments. What do you do if you want to understand how someone's range of motion is, but you can't put your hands on them? Well, guess what? I have an answer for that, folks. And these are questions that have been asked by the people. They'll be answered for the people by this people right here. Fam, recognize fam. Without further ado, let's debrief, shall we? The first question comes from my man, TJ. And he emails, types. I just had a question about the mandible. Can the lower jaw retract or retrude due to position of the head or spine or any parts of the body? If so, what positions make it retract or a compensation that would? Please let me know. Thanks. Appreciate it. TJ, this is a great question. I'm glad you asked this. I like talking about this stuff. It's kind of been going to be the focus of my learning probably late next year or late this year to however long it takes me to get good at this stuff. Let's talk about mechanics of the mandible in relation to the cervical spine. So I will put an article in the show notes that goes into this a bit better than I do. It's I forget what the article is, head and jaw position. But basically, they go into what position does the mandible go into in relation to the head and neck position. For example, if I go into a forward head posture, which would be OA extension with lower cervical flexion, the mandible is a bit more retruded. And in fact, if you want a good example of this, I will link a picture of myself when pre-beard that shows this exact posture. You'll see I have a forward head posture and my mandible is relatively retruded, and that's regardless of the occlusion that I have. So picture of me will be on there. I hate this picture, but I like showing it because it illustrates a lot of these compensatory activities that occur. When someone is assuming a military head posture, which is OA flexion and lower cervical extension, the mandible is more protruded or forward. So the relationship is, if the OA extends, the mandible retrudes. If the OA flexes, the mandible protrudes. And that's normal mechanics. If we relate that to the spinal mechanics during respiration, OA extension is associated with spinal inhalation, which would be all of the curves going more backwards or more in a kyphotic orientation. And I'll link a picture of that in the show notes as well from my manual because I care about you. Spinal respiratory mechanics. So everything's go backwards. So you get an increase in thoracic kyphosis, reduction of lumbar lordosis, sacrum counternutates. That's associated with OA extension and mandibular retrusion to a degree. When I go into OA flexion, that's associated with more exhalation. Actually, before I dive into that, the reason why the OA extends is to open up the airway. If you give someone CPR, you want to tilt their head in that position. Makes sense that the OA would go into that orientation based on when we're taking a breath of air in. As we exhale, the thoracic kyphosis reduces, doesn't flatten, but reduces back to the starting position. You get an increase in lumbar lordosis and the sacrum nutates. That's associated with OA flexion, which would create mandibular protrusion. Those are normal mechanics. Now, typically, for compensatory spinal or axial skeleton mechanics, one individual as a level 1 compensation is going to likely be more predisposed to more of a spinal inhale position or an exhale position. If we look at that from the head, you'll see people who either have more of a military posture or they have more of a forward head. Those are our two extremes, and one can be more biased to the other. Obviously, there can be rotational things going on with that, but to keep things as simple as humanly possible, since we're talking predominantly about retrusion, let's just stick with that. So if you see someone with a forward head posture, the jaw will be more retruded. And that can occur based on anything from the chain down. If you see someone who's more of a military head posture, you might not always see the mandible protruded, or the mandible will be protruded in this case. So that would be one way that you could get someone to have a retruded mandible, is if you have a forward head posture. The fix would be to address the spinal mechanics. So I would start this just like I would anyone else. You want to make sure you're restoring axial skeleton variability with a lot of the stuff that I talk about, infrasternal angle, getting hip extension, or posterior tilting. I'll link some stuff in the show notes if you don't know about that, but that's where it starts. Once you've done that, then you want to get upper thorax expansion anterior to posterior, including the pump handle and bucket handle. I'm not going to get all wild and crazy in that. I've done debriefs on that left and right. Don't worry, it'll be in the show notes tomorrow or tonight on zachcouples.com. So address this stuff first before you go tackling the head position. Now, in order to discuss what you need to do with the head for someone who has a forward head posture and retruded mandible, you have to consider what the orientation is of the hyoid. And I have to give a credit to Daddy O'Pops, Bill Hartman himself, for teaching me this. But as the head goes forward, you see a drop in the OA, or in the hyoid bone. So it's depressed. So you'll want to try to do things to elevate the hyoid. Now that doesn't mean you're going to be doing chin tucks left and right, but what you may do is you may have them nod slightly down. You can focus on swallowing based exercises to help elevate the hyoid, and all of that can be quite useful. A lot of times what I'll also do after I've done those things to address hyoid orientation is I will simply do drills to cue the jaw going forward, keeping the tongue on the roof of the mouth. So I'll see if I have pictures of that. But basically all you do is tongue on the roof of your mouth, keep it there, move your jaw forward as much as humanly possible, taking yourself out of the retruded state. Now, that's one potential compensation that you'll see. There will be some individuals who, despite having a military posture, i.e. OA flexion, they will also have a concomitant mandibular retrusion. The way this happens is I go into OA flexion, the mandible normally protrudes, but what they may do, and that would be a potential compensation to open up the airway, is they could potentially retrude on top of that. Those are a bit tougher cases because what that individual is trying to do is restrict range of motion, increase compression in the cervical region to better generate pressure or maintain stability within that region for whatever reason. We don't know why. That doesn't mean that they're unstable, but this could be another potential compensation you may see. For that individual, you have to drive things that emphasize OA extension. What that could be is simply tipping the head back, or as I like to cue, moving the chin away from the neck. And then I would also do the mandibular protrusion with the tongue on the roof of the mouth. I had a woman who was like this recently, and she was tough because she's had headaches for 20 years, really stuck in this OA flexed position with the mandible retruded, and what she was attempting to do to protrude the jaw was she'd have an open mouth posture, and she would jut her tongue forward so she could breathe, because that was her only option, because she essentially closed off the airway. And again, I consulted with Bill on this because I was struggling with her. And we ended up doing a lot of things to drive protrusion and a lot of some basic myofunctional exercises, which would involve the tongue. So we keep the tongue on the roof of the mouth. That would allow her to breathe through her nose, encourage opening of the airway. And some of the activities that we did were tongue on the roof of the mouth, moving the jaw forward and attempting to open without having the jaw retrude. That was a move that worked really well for her. We did side-to-side movements with the same principles. And I would have her do things to work on tongue stretching. So we would do that opening. We would do pushing the tongue forward. A lot of stuff that I learned from a man, Joe Cicinelli, who I will link in the show notes because he's a super sharp cat. We did a bunch of those things, and we were able to improve her neck range of motion significantly. But that could be your other case. Regardless of what the head position is, eventually what you have to do with these people is you have to move the jaw forward while keeping the tongue on the roof of the mouth. Now, if you've done all of these things to the best of your capabilities, and I would definitely encourage some type of myofunctional therapy if you are that far down the line that you've done all of the stuff that we would normally do as clinicians and you're still running into issues. I think myofunctional therapy is an untapped resource for a lot of these people who have that mandibular retrusion. If you can regain control of the tongue, I've seen that do wonders, not just in myself, but in some of the clients who I've experimented with. And in fact, it's an area that I plan on studying a bit more this, if not this year, the next year, because just playing around a little bit with some of my patients, I've seen some pretty phenomenal changes. So you may consider referring this individual who's got a retruded mandible after you've given them the baseline stuff to a myofunctional therapist, or learn myofunctional therapy on your own and implement it with your people. If you've done all those things and there's still issues, you could have a structural component to this. But that's after you've done all these things. Because what we're really trying to do with someone who's got a retruded mandible is improve the airway. And you have to address all components of the airway. Again, speaking with Joe, who's worked with a lot of people who've had to go the structural route. Now, I put a debrief in there because I've talked about this a little bit. Structural stuff for jaw. But sometimes if you don't have the neuromuscular components with this, a lot of those structural changes that you may have to undergo, they may not work. Whether it's splint therapy, whether it's something like orthotropics or even surgical procedures, if you don't have the neuromuscular component, you have to ask yourself what got them into that state in the first place. They're probably going to go back to their old patterns. Joe would argue that sometimes not doing myofunctional therapy in certain cases can lead to these surgeries not working. So I still think you have to address all these things. Moreover, this stuff takes time to change the structure of the jaw, and it's expensive. Not every patient that you work with or client that you work with is going to be able to go that route, and it may not be essential if you've addressed all the basics. A issue that I see a lot of people make is they skip some of these fundamental things and they go to some of the esoteric things, or not esoteric, but the more aggressive approaches out there, and they don't get better, and they're saying, well, that was a waste of time. Maybe it wasn't. Maybe if you had the foundation in place, those therapies would have worked a bit more effectively. So I can't harp on that enough. But that would typically be the step-by-step process that you would undergo if you had a retruded mandible and you were looking at improving that for whatever reason, whether it was temporomandibular dysfunction, whether it was headaches, whether it was neck pain, whether it was difficulty breathing, like a sleep apnea or a upper airway resistance syndrome. That's the process. So to outline that one last time, you want to start, well, you can get a retruded mandible if the OA is extended, or you have OA flexion and you have a concomitant mandibular retrusion. That would be a secondary compensation. Because normal mechanics would be if the OA is flexed, the mandible will protrude. That is accompanied with spinal mechanics, which I will link in the show notes. Your first line of defense is to address everything from the neck down. You got to set up that foundation. Many times that can improve mandibular function. I've seen it. I had a patient when I saw someone when I was in Boston, and he was getting a lot of jaw clicking, tightness, and all that. I did not touch the kid's jaw, and we were able to eliminate all of that clicking and all the jaw discomfort that he had with working on that stuff. So the stuff below the neck. So it's effective. Do that first. Once you've done that, then you can start doing some of the head stuff. If I got a forward head posture, I want to do things with slight OA flexion, emphasize swallowing to elevate the hyoid. If I'm a military posture, where the hyoid is elevated, I need to do things that drive OA extension. And once you've done both of those things, regardless of what your head position is, you're going to encourage mandibular protrusion with the tongue on the roof of the mouth, and you may also do some myofunctional stuff. Once you've done that, if you're still having issues, it may be a structural component. You want to go to a good dentist. I'll link a debrief that I had previously that will outline what you got to do for that. So, TJ, that was a long answer to a great question. Thank you for asking it. The next question comes from the legend himself, Dustin. And he writes, does your upper body variability hierarchy change when working with a pitcher because of GIRD, glenohumeral internal rotation deficit? I have a pitcher that has only 110 degrees of external rotation on his throwing arm, or 110 degrees of a total arc on his throwing arm. He has 15 degrees of IR and 95 degrees of ER. Dustin, this is a really good question. Short answer is no. It doesn't change for me. Because what I'm going to do is I'm still going to improve all of the components at the thorax and the scapula to see if I can maximize motion. And I would address things the same. I would continue to do bucket handle stuff, make sure that that's dynamic. If you have an IR limitation, you'll want to do some pump handle activities, which again will be linked in the show notes. And of course, last but not least, if a lot of these individuals also have a horizontal abduction limitation, you'll want to do things that drive posterior expansion. So you would treat them just like you would anyone else. One thing I may not do for these people is a lot of posterior shoulder stretching. I think that's, well, I think that's wholly unnecessary to begin with, because many times if you address the proximal or axial components, I've seen IR go full more often than not. Also, I believe Mike Reinhold did a really cool study, or it was either him or it was Kevin Wilk, on baseball players and posterior shoulder flexibility. And I'll link it in the show notes, but the point being was he's not a big fan of stretching the posterior capsule. It's not tight on a lot of people. So I feel like there's no point in doing this. And this was, I believe, Major League Baseball players. They likely have had some adaptations to be able to throw that fast. And it may not be just laxity in one part of the capsule, but it may be increased mobility in the entire capsule. So I feel as though posterior capsule stretching or posterior shoulder stretching is really more often than not warranted in this population. But if you do some of these activities and you give them a crazy amount of IR, shooting for that total arc of 180 degrees that we'd like in rotation, are you going to screw them up? Chances are probably not. Just because they have this amount of IR on the table doesn't mean that, and maybe they've lost ER to a degree, doesn't mean that that's going to be the case when they are getting ready to throw a 90-mile-an-hour fastball or faster. Likely the dynamics within the shoulder change because the constraints are different, the environment is different. So if someone's got aches, pains, discomfort, man, you want to get them as much movement options as possible in the shoulder. And then do what you would normally do. I don't see this as that big of a problem. And I don't think that just because you may even steal external rotation in a lot of these cases, that it's going to be lost on the playing field. I don't think we're that good. I think there are several steps in between that have to be bridged before we really make any meaningful changes to mechanics of any sport for that matter. just like if I were to do a passive stretch on a table, or maybe like a low-level tilting activity on a table, that doesn't mean that that individual is going to be able to back squat 500 pounds with perfect form. So why is it then that if we do a technique and we get crazy changes in shoulder motion, that we would expect an amazing change on the playing field? It just doesn't make any sense to me. There's a lot of steps that are missed. Doesn't mean we can't positively impact them, but it's probably not going to negatively alter their mechanics. So to summarize your question, Dustin, does the hierarchy change with someone who has GIRD who plays baseball? The answer is no. I would treat them just as you would anyone else. Give them options. Do what you do best and do what you can to support them in the playing field. You're still going to want to work on improving bucket handle, pump handle, and posterior thorax. And if you do those things, they're probably going to get more motion. They're probably going to feel a little bit better, and they ought to be in business. So, Dustin, great question. Before I dive into the last one, if you have someone who has GIRD and they have shoulder pain and you're like, I don't know what to do, or maybe you want to improve that motion to help them perform at a higher level because they're a baseball player and you work with baseball players, or maybe you work with people who have jaw issues and you're really good up here, but you're not so good down here in terms of the rest of the body. And by up here, I mean the neck and the head. And you want to take that component into your practice and improve that with your people. Well, I have an answer for you in terms of how to do that. And the answer is Human Matrix. And it is coming your way. We accept clinicians. We accept coaches because I'm tired of dividing those two. I want to make us into one movement professional who just works with people at different starting points. And I'm going to teach you how to do that by providing a comprehensive model to help all of our clients move better and more effectively reach their goals. If you want to come to my seminar, here's where we're at. I would say come to Hype Gym in New York on June 8th and 9th, but it's sold out. I do have a wait list available. So if you want to try to get in, you most certainly can. But hey, you know what? If you snooze, you lose on that one. I have a few other this year. August 3rd and 4th in Cincinnati, Ohio. August 24th and 25th in Vancouver, British Columbia. Boom. September 21st and 22nd in Raleigh, North Carolina. October 5th and 6th in Boston, Massachusetts. And last but not least for this year, December 7th and 8th in Orlando. The tickets are selling pretty fast. Do you want to miss another sellout crowd? I certainly don't. I hope to see you there. Without further ado, the last question comes from Corey. And he asks, "Hi, Zach. I hope all is well. I'm writing because I'm having trouble putting together an effective movement assessment for distance clients. And I was wondering if you have any material online or any insight to share about the topic." Obviously, you can't be as thorough with a distant client, and the table tests aren't an option. But I think it is important to establish some sort of movement baseline with all clients. I look forward to hearing from you. Kind regards, Corey. Corey, this is a really good question. So, for those of you who don't know, I happen to work with a fair amount of clients online, both in a movement consultation aspect where people, if they are having some issues movement-wise, they want me to look at them, I go and do that. I also do the same assessment with my training clients because I want to understand how they move. I want to know what variations I can and cannot use with these people to maximize their fitness goals. So in order for that to happen, I need to be able to assess them. The problem is I can't get an appreciation for a lot of the motion that I would normally get on the table. So what you have to do in this case is you have to find surrogate testing that gives you a close proximity to whatever it is that you're looking at. For example, one thing you might do is if, let's say you got your guy who's got GIRD. It's not perfect, but if you have someone who's got a shoulder internal rotation limitation and you want to see how well they do, you may do an Apley scratch test, which is the thing where you reach behind the back and see how far they can go. It's not perfect, but it gives you an idea of what you can do. That would be an example of a surrogate test. Now, there's several tests that I use, and I will give you the big three first-line decision makers. because I want to try to clean these 3 tests up as much as I possibly can before I move on to something else. So the things that are important to me, and actually there's 4. There's 4, I should say. The things that are important to me are, do we have movement capabilities in the thorax? Do we have movement capabilities in the pelvis? And that's what I direct my testing around. So things that I look at for distance clients, first thing I look at is I have them measure the infrasternal angle on themselves, which gives me an appreciation for bucket handle mechanics. The next thing that I will look at, and this gives me an idea of how well they can improve posterior mobility of their body or spinal inhalation. That would be a toe touch to squat. So it is as it sounds. I have them lock their knees, touch their toes. Can you go all the way? No. If not, then we probably got to improve posterior expansion. Same thing with the squat. The squat is going to also emphasize posterior expansion of the thorax, but also can they posteriorly tilt their pelvis effectively? If they either shoot their hips way back or they have a limitation in depth, we probably need to work on that a bit more. Once I've gone through that test, I usually have them do standing shoulder flexion with a backward bend, or if you're an SFMA person, a multi-segmental extension. This gives me an idea of, let me see, I'm going to write some of this down. This gives me an idea of, can I go overhead? How well is pump handle capability with the backward bend? Also does give me an idea of femoral hip extension, because if they can't move if the ASIS can't translate past the toes, they probably don't have hip extension. So it's another check, because you need hip extension to be able to get the posterior tilting of the pelvis. So that would be my second thing that I would look at. And then the last thing that I look at, which is a test that I got from Bill, is the standing propulsion test, which is basically like the wall drill that you would do for sprinting. Although there's a few different things that I look at, it's a bit more nuanced. Bill does a better job probably explaining it than I do, but the big things we want to see is, can they extend the hip on one side while keeping the opposite hip flexed? And that entails tucking, making sure the leg stays in a straight line, and driving the hip up to at least 100 degrees of hip flexion. You'll also want to see the ischial tuberosity displaced laterally as you lift up. So if you see someone's knee go out or knee go in, that can potentially be an issue with them being able to get into like a fully hip flexed position, or maybe they have some hip rotation limitations. But those are my big 3, or big 4, I should say, that I look at. It's infrasternal angle, toe touch to squat, multi-segmental extension, and standing propulsion. And if you're not good with those tests, that's okay. I mean, you come up with whatever. I've also used in the past, and sometimes currently, I'll use a split squat to assess single leg hip extension. I'll use a step up. You can use anything. I mean, there's nothing sexy about any of these tests. I go over some of them when I release my online product. Stay tuned for that. But that's typically what I use, and those give me a lot of information that I would I can make decisions off of. My first line decision. I have a move that gives me bucket handle. I have a move that gives me posterior expansion, which would be your toe touch to squat. I have something that gives me pump handle, which would be your multi-segmental extension. And then all 3 tests, the toe touch to squat, the multi-segmental extension, and the standing propulsion, appreciate hip extension in various ways. So what I do then is I go through those tests. I see which ones are the big rocks that are going to help me maximize my outcome that I and the client desire. And we do movements to see if we can improve them. And then we go back, and that's my retest. So that's basically what I do from a distance perspective. Yeah, there's other things I look at, but I've found with a lot of my online consults and my training clients is by trying to get these 4 things to improve as much as possible, it takes care of most of the movement limitations we see, and it gives my clients the most options available to be able to perform loaded activities. And I think it's a pretty good cluster. It's, of course, subject to change, but for right now, this has kind of been what I've been using for the past several months, and I would say I've probably gotten some of the best outcomes I've had online. So that's basically what I do. The key, regardless of what you use, Corey, is to find something active that gives you an approximation for whatever it is that you're looking for. If you don't look at the stuff that I look for, use stuff that matches what's meaningful to you. If you're big on hip abduction, think about all the active ways that you could assess hip abduction. Maybe it's a lateral shuffle for someone. Maybe it's just standing hip abduction. Maybe it's having them do a defensive slide. I mean, I don't know. It could be anything. But you just have to find a proxy measure, and once you found that, use that as your marker to test and retest. And if you see positive changes, not just from a visual perspective, but also from the client's perception. But if you can make those changes, you're probably going to get most of the table tests to change if you were to look at them in person. And I've worked with some people online, and then I've went and assessed them in person, and I've seen that. So you just have to find your surrogates, trust your testing, and make decisions off of that. And I think that's a good stopping point for us tonight. I want to thank all of you beautiful, sexy, outstanding people for tuning in to episode number 85. We're doing quite a few of these. I'm excited, man. We're closer to 100 episodes than not, so I'm hoping to keep this train going as long as possible and as long as the fam keep appreciating this. If you want to learn more, I'm not going to go into my whole diatribe. Just find me on zachcouples.com. There's a bunch of wild and crazy things there. And also you can subscribe to hear more movement debriefs on the Zach Couples Show on iTunes and Stitcher. I'm all over social media, although I've been a little bit low-key on social because I'm happier that way, I've found. So I want to try to stay as happy as long as I can. But I want to thank everyone for asking these questions. Thank you for tuning in. I want you all to keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.